day po. Come in. Good day. I'm Gavino, a second-year medical student, and I will be examining your ears, nose, and throat and oral cavity. So, how would you like to be addressed po, ma'am?
Marian.
Okay, Miss Marian. How have you been feeling lately po? Are you experiencing any ear pain or ear discharge?
None.
Are you experiencing any colds, cough, or decongestion?
None.
Okay, that's good. Are you experiencing any pain in your mouth, like toothache?
None.
Okay, that's good. Is there any sign of swelling on your neck lymph nodes?
None.
Okay, so far so good. So is it okay if I start now?
Of course.
Thank you. Have the patient sit straight with both feet on the floor. The examiner is seated opposite to the patient with legs uncrossed and both are on one side. The light source is positioned slightly above the shoulder on the side behind the patient. The head mirror is placed over the examiner's eye as close to the face as possible. Direct the reflected light to the patient. In examining the nose, we start externally. Note the shape, color, and patency of the nasal ala. Palpate the nasal sinuses, which are the frontal, sphenoid, ethmoid, and maxillary. This is done to determine tenderness, discontinuity, mobility, or any sign of fractures. We use anterior rhinoscopy to evaluate the nasal vestibule and anterior nasal cavity. With this, you will be needing a light source, head mirror, and nasal speculum. Instruct the patient to angle his or her head in a snipping position. Gently insert the nasal speculum inside the nostrils of the patient. Hold it properly while bracing your index finger. Assess the nasal floor, inferior turbinates, and anterior septum for any lesions or defect. We remove the nasal speculum by withdrawing it from the patient's nose with the blade slightly open. Accomplish this while avoiding causing pain and discomfort to the patient. For the examination of the oral cavity, we must first sanitize our hands. Make sure that the tools we will be needing are disinfected and wear gloves for the patient's safety. We begin by examining the lips with the mouth closed. Note the color, symmetry, and surface condition. We then ask the patient if he or she has dentures before we start examining the oral cavity. Have the patient open his or her mouth and place a tongue depressor for better viewing. Examine the gingiva, palate, tongue, and buccal mucosa. Have the patient maneuver his or her tongue to assess tongue mobility. If there is any changes, note the affected region and palpate with the gloved finger to determine consistency and depth. Place the tongue depressor in the anterior two-thirds of the tongue to inspect the tonsils. Note if there is any presence of swelling and exudate or pus. Have the patient sit in a comfortable and upright position. We start examining the ear by palpation of the auricle and surrounding structures. Note the shape and color, presence of swelling, deformities, skin lesion, otorrhea or discharge, and tragal tenderness if there are any. Repeat the same process to the other ear. With otoscopy, it is done by holding the pinna and retracting it upward, backward, and then downward to straighten the ear canal. The speculum of the otoscope is then inserted gently to the ear canal. We now proceed to inspecting the ear canal and all the quadrants of the tympanic membrane. Note if there is any presence of cerumen, the color, lesion, foreign body, and perforation. Perform these for both ears. With the examination of the neck, have the patient sitting upright. The examiner behind the patient palpates the cervical lymph nodes, tracing the preauricular, posterior auricular, jugulodigastric, submandibular, submental, superior cervical, posterior cervical, supraclavicular, and deep cervical lymph nodes. Palpate the posterior triangle of the neck, which is the level 5, then the central area of the neck or the anterior triangle, which is the level 6. To assess the thyroid gland, gently palpate for the isthmus and the lateral lobes. Ask the patient to swallow and see if the thyroid moves. So far, my patient is in peak condition. She does not manifest any ear defects, otorrhea, or perforation of the tympanic membrane. Her nasal examination was also remarkable. The nasal septum was midline, no congestion or erythema, no nasal discharge, and there are no tenderness in the nasal sinuses. The examination of the oral cavity went well. Her tongue and uvula was at midline, there are no bleeding or exudate, and there are also no noted difficulty of mobility with her tongue. Lastly, with the palpation of her neck, there are no signs of swelling from her cervical lymph nodes, and her thyroid is at center and moves with the swallowing motion. History taking and proper physical examination are both very vital to determine correct diagnosis and to provide right treatment and management. As future physicians, we must practice to master these skills to be able to provide optimal care for our future patients.